Good afternoon, everybody. Thanks for joining this session. This is, oh, sorry. This is an Ask an Expert session 4 where we will focus on digital mental health and reaching underserved communities. We have a brilliant panel of three experts for this session. Um, and my name is Cesar Escobar-Viera. I am um, faculty member in the Department of Psychiatry at the University of Pittsburgh. And this afternoon, we have with us three wonderful experts. I'll briefly introduce each of them before we move on to your questions directly. So, first, we have with us Dr. Brenda Curtis. Dr. Curtis is a clinical investigator, chief of the Technology Translational Research Unit, and an NIH distinguished scholar at NIH. The Curtis Lab pairs traditional methodologies with computational psychiatry to study the digital phenotypes of people who use drugs. While much of the lab's focus is on converting raw signals from digital data sources into useful clinical insights, the TTRU is very much committed to solving problems experienced by people in recovery and undergoing substance use treatment. Through clinical research, the Curtis Lab intersects addiction treatment, computational psychiatry, and innovative technologies. Using natural language processing, digital phenotyping, and deep learning, the lab focuses on enhancing precision assessment of substance use and behavioral predictors using intensive longitudinal data and integrating passive sensor data from smartphones and wearable devices. Among others, an overall goal is to develop personalized smartphone interventions for individuals living with SUD to enhance their recovery experience. We are also joined today by Dr. Giovanni Gio Ramos, who is an assistant professor of clinical science at the University of California, Berkeley, where he directs the Mental Health Equity in Access and Treatment MHEAT lab. Dr. Ramos earned his PhD in clinical psychology at the University of California, Los Angeles, and completed postdoctoral training at UC Irvine and UC San Francisco. His research combines a health equity lens, community based approaches, and digital tools to address mental health inequities affecting racially and ethnically minoritized populations, with an emphasis on Latinx populations. To achieve this goal, Dr. Ramos focuses on three interconnected research areas. Number one, identifying risk and resilience factors that affect the mental health outcomes of marginalized groups. Number two, enhancing the cultural and contextual fit of evidence based treatments, including digital interventions through data driven approaches. And number three, using digital tools to increase the accessibility of mental health services in disenfranchised communities. Last but not least, we are also joined today by Dr. Kelly Shaffer, who is an associate professor in the for Behavioral Health and Technology at the University of Virginia School of Medicine and co-lead of the Cancer Prevention and Population Health Research Program at the University of Virginia Comprehensive Cancer Center. She is a licensed clinical psychologist with expertise in psycho-oncology and digital health. The goal of her research is to modernize and expand psychosocial care delivery to people with cancer and their families through scalable and effective technology-based interventions. She currently leads a U.S. national factorial trial to optimize an internet-delivered sexual health intervention for breast cancer survivors through the National Cancer Institute Community Oncology Research Program. Thank you so much to our experts for joining us today. And The dynamics of the Ask an Expert session is basically to have an informal conversation where our audience is able to freely interact with our experts. So feel free at any point during the session to unmute yourself, turn your camera on if that's possible, and ask your questions to our experts. Um, and just to start us off for a second, I will I will ask the first question, and please, Brenda, Gio, and Kelly, feel free to freely interact with your thoughts about this question. And how do you guys think that researchers and private industry are responding to the unique challenges of working with underserved and diverse communities during this time?
Okay, I'll go first. I guess I did unmute first. I was just unmuting, but I think I mean, I can kind of point out from me as well as colleagues that are in the field that I work with. And I think that we are, addressing it head on. When I think about a lot of the models that we're building, working with this digital data, um, there's a lot of ethical issues that we are kind of facing right now. It's like when every old technology was new, when something comes on the field, there's new information, there's many things which may be just like things that technologies we developed in the past. But I feel like with the big data and the work we're doing now, there's some unique challenges. We have situations where we're collecting data on people who didn't ask to be in research. We're making models that could be built on biased data that could then just replicate biases and systematic issues that we see. Um, so one of the things I think that because of the harms of the past, I feel like a lot of researchers are very aware of them and doing their best to not replicate them going forward. So I think that we're responding in a way of just being sensitive and aware and really being thoughtful as we go through with what we're doing in order to ensure that we are inflicting no new harms on underserved populations and diverse communities, but also not creating new harms as dealing with various populations. So I feel like from a research point that we are trying to understand that there are differences and that these differences are important and that we should, do no harm as we move forward. So that's my motto.
Any other thoughts from uh, you, Kelly, or Gio?
Sure, I think at least in, thinking in the world of psycho-oncology and digital health in the context of cancer, I think we are trying to be really mindful about access to trials. So I work mostly in survivorship, and there's a real sort of compounding um, lack of access to clinical trials in that area. One being, a lot of there's a higher proportion of minoritized folks who are being seen in hospitals that don't have infrastructure for clinical trials. And then also survivorship care is much more likely to be attended by non-Hispanic white folks relative to folks from minoritized backgrounds. And so trying to be really thoughtful about when we're using clinic-based recruitment, going sort of the extra mile to make sure that we're making these trials available. Historically, clinical trials in oncology have not been particularly representative. And so I think there's a lot more scrutiny, both on, grant applications. You're seeing, I think, a lot more scrutiny on the proposed samples as well as your the appearance of capability to recruit those samples as well. So I think that's hopefully moving in a better direction in oncology.
I will have to agree with everything that has been said so far. I think at least from in my area of work with like working with racially and ethnically minoritized individuals, 2020 was a point of inflection in which it was like a wake-up call for a lot of individuals about the importance of doing this type of work and trying to reach groups that are normally, as Kelly was saying, are not even reached by our trials or by the products that we develop. So after 2020, there was like a big push to be more thoughtful of those issues. But unfortunately, now I feel less optimistic about these issues. I think now the pushback is happening, and now issues of equity, diversity are well, it's a research agenda that probably is not as fundable as it used to be maybe a couple of years ago. So I think I just sorry, I'm an optimistic by nature, but at the same time is there are reasons to be optimistic, and also I think now we are gonna have to be more mindful and crafty if we're interested in doing equity work in this area moving forward.
Thank you so much. I wanted to come back to some of your guys' ideas, um, and Brenda, you mentioned the risk of um, some of the technology that has been developing, and the interventions that people have been developing, sometimes including individuals who or using information or data from individuals that chose not to participate in the research and so on. We also face the challenge of how to make these interventions more effective or engaging with some specific communities. And I was wondering if each of you guys, from your own perspectives and fields, have thoughts on how to balance, on the one hand, the need of making these interventions effective for all, um, and for by that I mean think about the different specific um, communities, being racial minorities or ethnic minorities, or sexual or gender minorities, and so on, people living in underserved communities or rural areas, with also the challenge of sometimes start collecting information or data from individuals who maybe didn't agree to participate in the research, like Brenda was saying. How do we balance all of those aspects? Because we keep talking about that, the need of making the interventions more effective for all, but then we also face the challenge of how to reach out to those communities.
Right. So I do want to clarify just a tad bit. When I was talking about people being part of research that didn't ask to be part of it, I was kind of talking more like I do a lot of language analysis of social media and public spaces in that sense. And while it's social media, for example, is considered very public, the people in it consider it very private.
Mhm.
So while they're putting it out there and anyone can access it, it is very private for them. So for example, in cases like that, when we report, we never give like exact quotes or usernames or things. But to answer your question about how to how do we build things that are inclusive and mindful of the population, I really think that we have to do our best to include the various populations as we're planning our work, making sure our labs are here, everyone in the lab and in the planning of the interventions are able to have a safe place to speak about concerns or questions. We all bring our history to research. So even in the point of just our planning of the teams of how we're building and constructing our research teams, ensuring that we have a place where people can communicate. I think it's really important having, if possible, community advisory boards or at least some connection with people in the community before you roll things out. For example, are you planning to do a data collection point when kids are getting off the bus? And so thus, you're going to have limited people who can pick up, be part of it because they need to pick up their children. Um, so having people from the community look at what you plan to do, questions you're asking, as well as when data starts coming in and when data is in, how you interpret it and how you present it, I think are important. And I think that I'm an optimist too, to a degree. And I feel like if we develop things with a user-centric, a participant-centric approach, participants will stay and will join our research. They'll see that we're genuine and at least we're trying. I think that them seeing that we're trying goes a lot further than, we may not have the answer, but they're like, okay, they're trying to get this right. Because I'm in the field right now and we have something that keeps breaking and they're like, we know, let us know when it's working. And I'm like, oh God. But I think them knowing that you are trying and they will give you a lot of grace and a lot of space. So I think just being genuine, talking to people, as well as taking what they say and what they need and meeting them where they are instead of expecting them to come to our towers and meet us where we are.
I love everything that Brenda is saying, and I guess that yes, you need to be an optimist to do this type of work. If not, it's just impossible. Yeah, I couldn't agree more with the idea of involving potential users, community members in all aspects of this process, from the inception of these research ideas and research projects to the methodologies that we use and what are like actually the important research questions that we want to ask and answer. I think that sometimes we think of involvement of community members just at one step, type of like check, and I can move on. But actually, they can be integrated in every phase of the research project, and from inception to development and testing. Again, all aspects. The thing, and again, and I have advocated for those approaches as well, and I use those approaches in my own work. The caveat that I will give is being really mindful about that type of involvement and what is the specific goal, what is like the thing that you want to get out of that. And I think like a cautionary tale that I always like to tell people about is that in a very recent project, there were like amazing HCI, human computer interaction researchers, informatic researchers, clinical psychologists, and they had this amazing community partnership with a collective of racially and ethnically minoritized group here in the United States. And they were interested in using technology to address the potential mental health needs of this collective. And the approach that they took, it was, again, participatory design. Hey, tell me what you need, what are like some solutions that we can come up with. But I think that when they came up with these solutions, it was so open, they allowed them so many degrees of freedom that the potential users, they know what they know and they don't know what they don't know. So they came up with a lot of solutions that it was really difficult for me as a clinical psychologist by trade to identify evidence-based components from some of those solutions. So I think it's important to balance this desire between the preferences of the users, but also their needs. And I think a good combination is between you have the expertise about what is the evidence base, but they might have the expertise about the packaging or what is going to work in terms of that specific context. So in a way that this involvement from community partners doesn't go like sideways.
Yeah, Gia, I couldn't agree more with everything you just laid out there. I think sometimes we, yeah, inadvertently put our, community helpers in a tough place. We leave things too open-ended. Cesar, I am not sure. I thought I heard this in your question, so it may be a little bit tangential, but this concept of personalization to improve engagement is something I think our center has really been like going really like back and forth and and really trying to find like trying, kind of going around on that topic. We, my colleagues had this really awesome study where they took our evidence-based cognitive behavioral therapy for insomnia digital health program called Shut Eye, and tailored it, revised it for Black women. So working with the Black Women's Health Study up at Harvard, did an overhaul of the program to make sure the content was all relevant and all of the stories and the physicians who were interviewed were all Black women. Really, really cool intervention and sort of tailoring of the intervention. And that trial comparing, shut eye for Black women versus shut eye versus, control, and a sample of all Black women. We found, my colleagues found sort of a pretty substantial impact of tailoring on engagement, which, as you would imagine, about 20% higher completion rates. And completing the intervention is important for getting the full benefit, although there weren't on average differences across the conditions. So we're still sort of struggling with that finding a little bit. But meanwhile, we also have a shut eye for older adults. And we're also developing shut eye for family caregivers, and thinking about how do we then layer when we think about intersectionality. So what if we have an older Black woman come in? Does she get shut eye for older folks, or does she get shut eye for Black women? Or are we working towards layering these programs on top of each other? It is something that hopefully we will be more able to do as we, AI is doing incredible things. And so hopefully we're moving into this era, but it is very technically complex. So it's something that we're just really trying to think through right now.
And it's so interesting that you mentioned that, Kelly, because on one hand, it's that the type of research that we need, because sometimes we assume that we need to create these super tailored interventions because they are gonna obviously lead to better engagement and better outcomes. And the funny thing is that we have done that in the face-to-face literature for 20, 30 years, and we know that that's not happening, at least in the face-to-face intervention. And I think that's one of my biggest beef right now in the digital space, that we are replicating research agendas that led to like these alleys without like exits. And I don't know if actually that's the best use of our resources that are so limited. And now more and more that this type of work is going to be limited in terms of the funding that is going to be allocated to. I think this work is needed, but I think we need to be really thoughtful and make sense of the data. In this particular case, something that came to mind for me, it's just potentially for a lot of Black women, seeing themselves represented, maybe it's the initial buy-in, so they use it, but once they use it, maybe the content doesn't need to be tailored. So maybe it's about the reach, the initial engagement, but the evidence-based components maybe work equally well. But if that's not the case, I want data to suggest that, oh, maybe they are engaging less in cognitive restructuring. They are actually they don't have these decreases in experiential avoidance, whatever the case is. But I think given once we have that data, we can really pinpoint the adaptations that are needed instead of assuming that we need to adapt without like a specific guidance.
So I don't want to say how many years ago, but this was my research dissertation, which was I think Mario Kart, right? I pinned the look and feel, so tailoring on age, gender, ethnicity, things like that. And then I studied under Marty Fishbein and then tailoring under the theory of reason action. And so the idea was like look and feel versus content, right? And so people were from all these different things, either 0, 1, tailored on an item. So you had, all of this huge design of being tailored on 0 all the way to being tailored on like 20 different things, right? And every variation of it, seemingly unrelated regression analysis and a whole bunch of other stuff that I don't know how to do anymore. Guess what? So look and feel got people's attention. it made them more engaged. They felt like it spoke to them. It was more persuasive. They would share it with a friend. But then the content of it, like, did it address that it was a smoking prevention or smoking cessation, that their partner smokes and then they need to kind of figure out ways to get their partner to stop smoking because they live with their partner. So it was like concrete theory of reason action was what made the behavior change, but getting people to be engaged with it was the look and the feel of it, or the message persuasiveness. I'm not saying this is the real world like today, but that was just this one study. But it has come true with so much that I do today. It's like people we once we kind of cut the, get to that, like, this looks for me, people even made an effort to make it like speak to me, then they want to know like what's in there. And so, like, when I think about what hat I'm wearing, sometimes I'm wearing Brenda the researcher hat, Brenda the mom hat, Brenda Black woman hat, Brenda from the Midwest hat. Like, there's so many hats. I can't imagine, like, maybe with AI we'll start doing it, but then you get to the point it gets creepy that you're like trying to like pander to me. So I don't have an answer completely, but I love the conversation because this is where we're at. And I do digital phenotyping. So we get all of this like digital smartphone data, and at the end of the day, like the meeting I just got off of, I was like, do we really need all this stuff? Because language tells us nothing is beating language. Like nothing is beating analyzing a person's mood and what they say in a session. So why am I doing all this other stuff? I don't know.
Thank you so much for all these wonderful exchange. I wanted to open um, the opportunity to our audience, and I want to encourage anyone to chime in and ask your questions to our experts.
Well, people do that, and please don't be shy. Ask us things. Let's make this fun. Brenda, please share your dissertation with me. I would love to take a look at that data. Yes, just I know that you just conducted it like 2 years ago, because obviously. I would love to take a look. And but I really love what you're saying. Like, just what is like the best use of the limited resources that we have, and then I think and maybe this is not super popular. This is not a super popular opinion, but I'm more and more advocating about making treatments that we know are strong in terms of their evidence base and make them widely available. I think just based on my read of the literature and the own work that we have done is the issues reach. We do a terrible job at reaching people, but once we are able to engage them, they tend to benefit from these interventions. And in my particular case, working racially and ethnically minoritized individuals, there's some emerging data showing that they engage more compared to people from more well-off backgrounds. So sometimes the way that I'm making sense of this emerging data is there are so limited options for them to engage with mental health services that is like, finally, I have something.
Mm-hmm.
So they really latch to it and they use it. But the issue is, again, we are not reaching them. We don't design or interventions or studies to reach them. But if we do that type of work, I am a believer that as long as you're providing a good evidence-based intervention, I think they are going to benefit. And if you are able to reach those populations, then we're going to have the data to make comparisons and see if we actually need to change things, if we need to tweak things.
Thank you. We have a question from the audience. Nikki.
Hi, thank you so much, everybody. It's been wonderful listening to everyone's backgrounds and experiences. Building on kind of the conversation that we're having right now, I wonder how we can go beyond just simply like translating things or putting things into a more colloquial language for different groups to tailor them to that whole look and feel aspect that Brenda, you were just touching on as well. And I'm asking this from the perspective as well in my own work that I do as a clinical psych post-bac researcher at UC Davis Health, working on the early psychosis intervention project. A lot of our kind of outreach and community-based work to reach diverse audiences is mostly just translation oriented. And that's a lot of times where I feel like sometimes that outreach ends there. And I'm just wondering if there's any other more maybe hands-on methods that you guys have seen in your work that really integrate culture and community into care.
Yeah, so I am very much not the expert here. So, but I did recently, we're working on getting some funding to transcreate linguistically and culturally tailor my sexual health program for breast cancer survivors, for Spanish speaking breast cancer survivors. And you know, to your point, it is not just about the language, but I think Gio and Brenda's, you know, speaking about it as well, is thinking about what are the components that don't culturally translate and what are the components that do. You know, the experts that I'm paired with to work on with this, who do this work, you know, just thinking really carefully about going to these communities and setting them up with good questions, to be thoughtful about the directions, and to think about yeah, what are the evidence-based components that work kind of, you know, no matter what the community is, versus, you know, for example, you know, part of our intervention is communication skills training with your partner, and that's going to look a lot different in different cultures as well. So thinking about what are the, you know, those components. A metaphor that I really like when thinking about tailoring is from the literature, and I should cite that person who said this, but I'm forgetting off the top of my head, but he talks about tailoring as thinking about what parts of your intervention are like a suit and what parts of your intervention are like socks. Socks, we pretty much have 1, 2, 3 sizes that kind of fit everybody. You don't need a whole lot of tailoring for socks versus a suit. You're really going to want that to be pretty tailored. And so, you know, being really thoughtful as a clinician about what are the pieces that need real attention versus what are the pieces based on all of, especially the face-to-face literature over the past decades, might need less.
I think something I have found really helpful here is like the involvement of the community members, even sometimes just language that you're going to use for your recruitment materials. What is something that actually is going to resonate with those communities versus actually turn them off? And sometimes we make assumptions about like, I know like what those people need. And maybe like the best way to go about this is just like ask them like, hey, what do you think about this? Like what is resonating, what is not resonating? I think in our work, we have been really thoughtful about trying to depict individuals from the communities that we are trying to reach and use language that they report as less stigmatizing. A lot of our work, and this goes back, that's just recruitment, but also going back to even the rationale behind the study. Like some of our studies, we have moved away from needing people to meet criteria for certain disorder versus just like experiencing certain issues related to race and ethnicity. Not surprisingly, we have done really well in recruiting these individuals. I hear the term hard to reach is no, we do a really poor job at actually speaking in a way that makes sense to them. And once again, so involvement from the community in terms of like the recruitment materials, but also the research questions, the things that are important to them. When you design something that resonates with them, you will be surprised. Actually, people go and engage with that. And the last thing that last point that I will try to make is partnering up with like those key stakeholders, people in the community that really understand the issues of those in those settings. I think there are, just based on the really bad track record that we have as researchers, there's no reason why for community members to trust us. But if you have sometimes a community member that vouches for you, it's like, hey, this person is legit. This person is not here to just take from the community and never appear back. I think that that really goes a long way. And that comes like there's no shortcut about building those relationships. You have to show up consistently, not ask for things, and just being genuine about why you want to partner up with them. And that takes time. And I don't know any shortcuts on how to do
Yeah,
it.
two things. I one thing that I do when I'm working with community organizations, I'll start at that level, like in the sense of maybe they're letting me into their space to recruit or to do an intervention or to do research. I do ask them what do they need and like kind of like what would help you? Is it me coming to your board meeting? Is it saying that you're partnering with blah? Do you need a survey? Do you need some data? So trying to figure out and not making promises I cannot keep. Like you really cannot do that. Like know what you can give and know what you're able to, and also don't set yourself too thin. But so that's one thing I try to do is to like working in spaces, trying to see how I can make this mutually beneficial. And the other thing I do, which maybe I play too many video games or used to play too many video games, is when I develop digital interventions, a lot of time I let people choose. Like I'll say, do you, and we're getting to the point now where we can have so many different languages. I'll say like, do you want this spoken to you in any language of the ones that we have, or do you want the language on the screen in that way? So I can let people pick like what they want. Sometimes people like to read English, but hear another language or back and forth. So I'll let people pick, and I also let people like pick their speaker sometimes. Like I do a lot of avatars. It's just easier because you can have like a a visual, and then you can always swap in voices, so it decreases cost of development. But then I'll have people like sweep in like video clips, but I'll have people like pick their avatar and because maybe they want a female version or maybe they want a male version or a neutral version. And so I try to build things saying for the most reach, but it not letting people pick who they want. It's just like a video game when people pick. And sometimes even when I'm working with adolescents and young adults, it will look like a video game in the sense of kind of picking the pieces of this that they want, who's going to be their narrator through the intervention. And now we're moving to chatbot. So we're actually working on a test right now on similarity, where there's been research that more similar the speaker is, the more likely you are to engage. And so what we're doing is taking a screenshot of the person and then morphing the avatar that's going to be the chat bot picture by like 30% like them. And that's supposedly enough to switch voting, but it's coming out of the political science literature. So we're doing one test on similarity and we're doing one test on how human is it? Like if it stutters or does typos or does things like human do, is that more engaging or less? So I think I went a long way in answering your question, but um, I like to let the user kind of pick what they want.
And from that, like that reminds me of some of the conversation about like this balance between how much degrees of freedom you provide to potential users, designers, and just making sure that the evidence-based components are still there. Now my conversations with designers are more about like, okay, and how do we give people agency so they can make a lot of choices? Because I think that's really important for them, while making sure that you give them, I don't, and this is not in a cynical way, but like kind of like false choices. Do you want broccoli or do you want carrots? Do you want to do weights or do you want to do cardio today? So in a way that actually they get to choose what they want, but they get to choose something that you know that is going to work regardless.
Yeah, I, we had a situation where one of the researchers in my lab wanted to test having the chat bot if it came from like Google or a university or NIH or this. And I was just like, we can't lie ever. So it's never going to come from those other things. So why are we even testing that? It's either going to come from a university or the government. Um, yeah. The idea of the choices we give them. Also, sometimes choices like oh my God, I have had adolescents spend 10 minutes building their character when they only got 20 minutes to do this and they've spent half their time building their character and didn't get to the thing that they're there for, the content. So your mileage may vary.
And difference in again between choices and preferences and needs. In one of my studies, people hated the text reminders, but they truly hated them. It's like the most annoying part of this study was receiving text messages, and the engagement was amazing. So I was like,
I can relate to that.
yeah. So maybe sometimes this reminds me a little bit of exposure in clinical psychology. I don't know any like user or client who is like, oh, I love doing exposure therapy with you. No one says that. That said, it's really effective, and sometimes that's what you need.
Let me follow up. I think you guys have been covering a little bit of this question already, but can you share some success stories from your work on ways in which you have engaged with different communities in order to design or develop any of the tools that you've tested throughout your career? Kelly, would you like to start maybe?
Sure. Um, y- I think I'm not going to answer your question directly. And so I'm sorry to be the one to start, but you did say success, and I wanted to share a different success. That's not about intervention development, but about recruitment and engagement into trials, which I think, again, is a real issue in oncology. And so we are doing in-clinic recruitment through the NCI Community Oncology Program, which is sort of clinics that are not almost vast majority of them are not connected to an academic medical center. So sort of gets trials to places that don't normally have access to trials. And when we opened our sexual health study, we were just not sure what we were going to get in terms of recruitment. We were hoping for like 9 to 10 enrollments a month across the US. And we ended up with an average of 40 women enrolling. We had enrolled 200 women in 5 months. The issue was that was almost all non-Hispanic white women. And we have this national network. There's no reason why that should be the case. And so we sat down with the Health Equity Committee to really think through what are some reasons for this, take a real look in the mirror about whether this intervention was, catering specifically to this group. And we made a pretty radical decision. I don't know, maybe it's not that radical. But we closed recruitment to non-Hispanic white women for that trial. And, people were like, well, that's like, you're not going to be very successful. We ended up meeting our original recruitment plan. We were still enrolling 9 to 10 women a month. Of minoritized racial and ethnic backgrounds. And it was really just, I think we had to really purposefully redirect people's attention away to these maybe like perceived as lower hanging fruit participants. And again, having to do a little bit more outreach because fewer women were sort of coming into the clinic. But we were able to round out our trial and meet our original sort of demographic targets that we were hoping to meet for that trial. So I'm really grateful that we were able to kind of take that step. And every trial that I run from here on out, I want to be just so much more thoughtful and purposeful about reserving space in our trials for minoritized women and making sure that folks have access to our trials. So anyway, that is not answering your question, but a different win that I'm really proud of. So hope that's okay.
Oh, I believe it's a great success story. So thanks for sharing.
Can I share something along the same lines? Because that really resonated with me. The fact, once again, like the ideal participants or the participants that we over and over again and reach and overrepresent in our studies versus maybe some other populations that we want to reach and engage in this type of work. Again, just going back to 2020, and I know that 2020 was an amazing year and we are all trying to forget about it. But at that moment, there was like 3 things happening in the United States that really made services for racial and ethnic minorities so important and needed. We had an administration that had like a political discourse that was hostile against some of these groups, and it's well documented in the literature. There were increases in instances of discrimination against certain groups, and later we have the pandemic and how some racial and ethnically minoritized groups were demonized and blamed for this health crisis. So again, increases in discrimination. And yeah, so like just taking into account the things that were happening, to me, it was obvious that there was a need for mental health services for racial and ethnically minoritized individuals who experience discrimination. So taking advantage, well, not taking advantage, but like trying to address that situation, we designed an intervention trying to tackle that. It was a self-guided mindfulness-based intervention for people of color who experience race-related stress. And we tailor all our materials to try to depict individuals from those groups. We use, again, language that was less stigmatizing, but it was about like, hey, this is about experiences that maybe resonate with you. And despite being a hard to reach population, within a month, we had already met half our recruitment goal. So we had to expand recruitment. We doubled our recruitment for that specific study, because I think this project was really resonating with people, the needs of the community. And I think that's just my takeaway, is that when you're mindful about the people that you want to reach and you really speak to their needs, you're more able to engage them in this type of work.
Well, I will say we did not plan this three. I think we got a trifecta. I agree. I have had amazing success with recruitment and Forex recruitment, and I think it's because of the relationship forming and the thought going into building. I remember one of my first studies was called Do You, Do Me, Do Condoms, and it was a program we did with adolescents. And it was when Cabrini Green Housing Authority housing facility still was in Chicago. And I spent the summer with adolescents talking to them. I had a group of girls and guys talking to them, or people talking to them about what they were experiencing and how they were negotiating or wanted to negotiate condom use with their partner or partners. And so they helped me, we developed the scripts, then we did the videotape, and then we like made this interactive video type thing where you could like choose your adventure and kind of like, get tips on how to talk about condom use with your partner. And then moving on to like, another program we did where the school gave us a room where we were going to have screening and brief intervention for drug use. And we let the kids vote on naming it. They voted on the snacks we were going to have. They helped us decorate it of like stuff we were going to buy. And it really became like this student room, almost like this clinic where we had to say, you're kind of only supposed to be here for therapy and counseling. But, then we actually ended up making like a little side area so that they could like just chit and chat. Um, Kind of this idea of like really working with people and doing that, but even just like being consistent, like I think I kind of feel like maybe because I am from the Midwest and the South, like when people come into our spaces having like snack bowls that, have some snacks and like some fruit or different stuff that being here, I have to pay out of pocket. If you don't, I'm not telling people to pay out of pocket, but just like having something that's kind of warm and inviting and you know, mood music, having good music and good lights, doing things to try to let people know, like, I'm trying to make this comfortable for you. Because I think it's really hard, people coming into these spaces, just even walking in the door and going through the guards or going through whatever, even if you think it's not intimidating, a lot of time it is intimidating for them.
Well, thank you so much, everyone. We are at the end of our time. I really want to thank our three experts, Kelly, Gio, and Brenda, for their time this afternoon. And please, we have a 10-minute break right now, and then we continue the conference activities this afternoon. Thank you for participating.